Hi there, my dear colleagues. My name is Nap, your Antimicrobial Steward. I intentionally decided to compile this short video due to the frequent number of times we have been preaching the hospital AMS policy lately. As a hospital, we intentionally chose to restrict the use of a number of very useful antimicrobials because we live in dangerous times indeed, times that can be summarized as bad bugs, no drugs, which can be paraphrased as times during which we encounter infectious diseases caused by microbes that are resistant to literally all the antimicrobials in our arsenal. Antimicrobial resistance is a very gloomy reality in Kenya and the world over today, and the antimicrobial pipeline remains very dry. That is to say, no new molecules are being manufactured by the pharma industry to help us manage the superbugs that we frequently encounter in our line of duty. It is with this background in mind that world-class institutions like AKUH N University, Nairobi, have deliberately decided to promote the judicious or rational use of antimicrobials so that future options for managing the ever-increasing number of infections caused by multi-drug resistant organisms are preserved without necessarily compromising on quality of medical or clinical services that we offer to our esteemed clients. As a hospital, we also seek to contain costs of treatment without causing harm to these same clients. All these and many more elements executed in an orderly fashion in a coordinated manner by an organized committee constitutes what we define as antimicrobial stewardship. At the AKUH N University Hospital, we strategically and intentionally selected 15 antimicrobials with unique characteristics or specific indications, which, if used irrationally or rampantly, would deny future generations to come very useful treatment options for the ever-increasing number of infectious diseases that we encounter. Now, as a hospital, we have categorized these antimicrobials whose use we restrict in two categories, namely 1 and 2. Now, in category 1, we have restricted antimicrobials which have totally no role in empiric treatment, but they remain very useful in combating the ever-increasing number of multi-drug resistant organisms. These include 2 echinocandins, namely caspofungin and micafungin, which are very useful in treating conditions such as candidemia or any other fungal infections that are susceptible to these antibiotics but are resistant to the frequently used antifungal fluconazole. Now, fluconazole resistance has mainly been driven by its widespread use prophylactically among the very many HIV patients that we meet or encounter in healthcare. Now, we also have linezolid in both tablet and injectable form. Linezolid is useful in the management of vancomycin resistant enterococcal infections and in the management of MRSA. Now, we can't afford to overuse the two forms of linezolid because prolonged use results in conditions such as thrombocytopenia and neuropathy, which would complicate the states or the conditions of our patients that could cause harm, and our goal is to avoid causing harm to our patients. Now we also have planning, which is useful in the management of VRE, vancomycin resistant enterococcal infections, as well as MRSA, when vancomycin is unsuitable or not a useful option. Apart from that, we also have a glycylcycline by the name tigecycline, which has a very broad spectrum, but it also has the downside of it, a very large volume of distribution. This is a highly lipophilic glycylcycline. Now when it's infused during therapy, it widely distributes in the body. Now we end up with very low serum levels of the antibiotic, and because of this it's not very useful in management of conditions such as bacteremia, and it has no room in monotherapy because of the low serum levels it attains. Now at the Aga Khan, we recommend its use strictly in the management of MDROs such as Acinetobacter, Baumannii infections or Klebsiella pneumonia infections, alongside the polymyxins. I would like to underline that we discourage its use as monotherapy. Apart from that, we have two polymyxins in this group, namely polymyxin B and polymyxin E, which is also called colistin. These are our last line of defense when used alongside tigecycline in the management of infections caused by multi-drug resistant Acinetobacter baumannii or Klebsiella pneumonia or E. coli, among other conditions. All antimicrobials in this category require prior authorization by the ID physician on call. It can also be done by a designee of the ID physician on call, who can be an ID fellow rounding with the physician. Apart from that, approval can be sought from an ID physician, a qualified ID physician consulted by the team managing the patient. Now that means that antimicrobials should only be dispensed by pharmacy staff after the ID physician or the ID team has alerted or informed the clinical pharmacist on call during that week, the one handling the hotline. Now they should furnish this clinical pharmacist with information about approval basing on clear rationale, e.g. culture and sensitivity results. Now we as a department must adhere to this without any exceptions, and this is not negotiable whatsoever. Now category 2 of the restricted antimicrobials consists of carbapenems such as Doripenem, Imipenem, cilastatin, Meropenem, and Ertapenem. Now these are very useful in treatment of susceptible gram-negative rods and some gram-positive microorganisms, as well as microorganisms that may cause conditions that cephalosporins may not be effective in. Now they are broad-spectrum antimicrobials that, if misused, however, may drive the emergence of what we call the carbapenemesis. They may drive the proliferation of bacteria that produce the carbapenemesis. Now this would further complicate management of infectious diseases. Apart from that, we have Piperacillin tazobactam. Now this serves as a carbapenem sparing option in the management of susceptible infections caused by susceptible gram-negative rods such as Pseudomonas aeruginosa. It's also very useful in the management of many intra-abdominal infections. Apart from that, we also have two anti-pseudomonas cephalosporins, namely Ceftazidime, a third-generation cephalosporin, and Cefepime, a fourth-generation cephalosporin. Now, their rampant use drives the emergence of bacteria that produce what we call cephalosporinases, the extended spectrum beta-lactamases. So we discourage unjudicious use of these two cephalosporins. Lastly, we have Vancomycin, that is very useful in the management of susceptible forms of MRSA. Now, when category 2 restricted antimicrobials are prescribed, pharmacy staff are authorized to dispense them. Now, by 48 hours after the initial prescribing is done, the clinical pharmacist on call is supposed to remind the prescribing physician via an SMS message of the need to seek an ID consult. Now, the ID team should review such a patient and make a decision on whether it's rational to continue using the category 2 restricted antimicrobial or to stop and change treatment. Currently, in the event of lack of consensus between the ID team and the prescribing physician, the prescriber can have his way. They can choose to continue treatment with the same antimicrobial. Now, when this happens, the clinical pharmacist on call should, however, send an email to the chief pharmacist informing her of this lack of consensus. Now, the chief pharmacist in turn should send a similar email to the chief of staff. Now, the chief of staff can arrange for a peer review meeting of prescribers who continually defy recommendations by the ID team. So, pharmacy staff should never ever auto-stop any category 2 antimicrobials, since this is a measure that we put in place to avoid cases or incidences where the patients miss doses, as this would negatively impact on clinical outcomes. Now, I urge you, my esteemed colleagues, to be good antimicrobial stewards. I can't fight this battle alone. Now, if as healthcare workers we continue using antimicrobials unjudiciously, this grave situation depicted here in this cartoon will become a reality. I'm sure you would not like to be in this kind of situation. So, in summary, please do not dispense category 1 restricted antimicrobials without authorization by the ID team, as has been happening lately, as this grossly breaches the AMS policy that the hospital has in place, and it undermines the gains which we have made at the AKUH University Hospital Antimicrobial Stewardship journey, which began way back in 2017. So this is not negotiable, my friends. And finally, I would like to applaud the entire department for placing the AKUH University Nairobi on the global AMS map. You are way ahead of the pack in the region, so keep up the good work, maintain the momentum we've created, and continue offering safe antimicrobial therapy to our esteemed colleagues. Thank you very much, my colleagues.